So we will start. We'll start first of all with a very common clinical scenario that we see every day, which is occludable angles or primary angle closure suspect. So should we do a laser PI in all these patients, or is it prudent to observe some of them? So to talk us through this, we have Dr. Thomas George, a very senior respected glaucoma surgeon from Chaitanya Eye Hospital, Trivandrum. Thank you.
Thank you, Kiran. Good morning, everybody. Can I have some of my slides up? Yeah, thank you. So let's go through laser iridotomy to do or not in angle closure, primarily in angle closure suspect, PACS. So angle closure glaucoma, we have got it, when we talk about primary angle closure, we expect it to be a relative pupillary block, and an iridectomy or iridotomy is expected to be curative, and laser being easier, we do laser PI more often. Now, the questions I'll try to address is, do we need it? Does it work? Especially in the primary angle closure suspect stage PACS and PAC. Both of these situations, we do not have high intraocular pressure or disc changes. One of the first studies that we got some info on it was Velour Eye Survey. The primary investigator is right here, Ebi. And 22% of PACS progress to PAC in 5 years, and none to PACG or glaucoma with optic neuropathy. So PAC to PACG, we knew that 11% who underwent PI progressed, and 36% who refused PI progressed. So we, when we look at the Chennai glaucoma study, the incidence of primary angle closure disease was 4% in 5 years. That is deemed as normal. Converting primarily to PACS is in 5 years. And so we know from these two epidemiological studies that the incidence of PACG is low even in PACS and PAC. And PI does not protect everybody. It does give you some protection, but not for all. More recent evidence has come from the two studies which are popular now, and that is the ZAP and ANALYST trial. ZAP is, I don't know how to pronounce that, Zhongshan Angle Closure Prevention Trial. It screened a lot of people, 11,000 people for eligibility, and they found 870 subjects would fit their criteria. They did PI in one eye, and the other eye was maintained as a control. They had a 6-year follow-up, and all the subjects were from this particular area, which is in South China. For diagnosing PI, one of the problems there was no indentation gonioscopy was done when they diagnosed PACS. A 2-quadrant pigmented trap not visible with no PAS or disc changes, and IOP being less than 21 was our inclusion. Excluded those who had IOP rise because they had prone provocative tests and dilatation as part of the inclusion, and those who had IOP rise were excluded. Those who needed immediate treatment, such as those over 30 mm Hg, was deemed as needing immediate treatment in standard care. I don't know why it's mentioned separately, because IOP was less than 21 to start with. And 454, about half of them had OCT, anterior-segment OCT, and 26.4 had residual PACS with OCT. That's about a quarter of the patients did not open up with PI. And primary angle closure occurred in 4.19. They reported in 1,000 eye years as their reporting strategy. So 4.19 in treated eyes and 7.97 in untreated eyes, so approximately half. And primary outcome occurred in 19 patients and 36 patients in the 72 months of follow-up they had. That's the absolute numbers. And this was significant. When mostly the difference was development of a PAS. So it's PACS to PAC. So it's about a half reduction that you get with PI in terms of risk. And incidence of PAC in PACS is low. We still repeated what we already said. And we go on to the next study, which was done by some of the investigators who were involved with ZAP, and so a lot of problems were sorted out at the design level itself. And it was multicentric and in Singapore. 480 individuals over 50 years, bilateral 2-quadrant apposition was required to be counted as a subject, PI in one eye, other eye control, and outcome was PAC, that's Sinike, or IOP over 21, or developing an acute closure or optic neuropathy at the design stage. Most were Chinese, most were women in this group that was studied, 92% Chinese and 75% women. And 5% of the treated eyes reached an endpoint, that is at least PAC, and 9.4% developed PAC or reached the endpoint in the control eyes. So PACS to PAC was 5%, with PI, without PI, 9.4. So the adjusted hazard ratio, which again was 0.55, once again reiterating, about half would be benefiting when you do a PI. The older patients had a higher hazard ratio. So just like we talk about open angle and say thin cornea as an extra risk factor, age is a risk factor here to be considered. Higher baseline IOP again had a higher hazard ratio. So that again is another risk factor which we factor in when we eventually think about whether to do a PI or not. And the number needed to treat for the whole lot for one person to get a benefit was 22. So out of 22 patients, we prevent one developing a PAC. I'm just going through the calculation there. Okay, so now we know that the risk of progression reduces by about half with a PI, and it is not eliminated. Absolute risk of progression without PI is also not very high. So at the end of the day, PACS to PAC, the risk is a low incidence, so PI can be done, or we can watch the patient and keep a patient on follow-up. Both have rationale right now. PI does not prevent closure in all. So doing a PI does not absolve us from the need for follow-up. So on a case-by-case basis, older patients and higher IOP, go for a PI. If he needs repeated dilations, go for a PI. Otherwise, you're justified in just watching the patient, keeping the patient on follow-up, 6 monthly or one year gonioscopies to see if there's a progression, and if there's a progression, intervene. Just like we do for open angle. Feel progression, we get more aggressive. That sort of situation. Thank you.